Well, welcome back. In this part of the training, we're going to concentrate on PowerPoint case presentations, and we're going to look at two focal points of interest. The first being an introduction to laser physics and science. It's the keystone to understanding how to effectively use your laser. You don't have to be an Einstein to be able to use laser for dentistry, but if you understand some of the basic concepts that I'm going to go over with you, it will sincerely help your efficacy when working with patients and not overdoing the power settings and being able to understand exactly what you're doing with the laser. And I think it's a key component to have an understanding of laser physics and laser science. After that, I'm going to go through the top 10 procedures that are done with the diode laser, and we'll concentrate on some clinical cases showing you some video and some still photography shot through the operating microscope that we use. I think that for many clinicians, they become frustrated with the fact that their diode doesn't seem to be operating fast enough. It doesn't seem to be cutting quick enough. And I think the more that you can improve the magnification of the operating field, the easier it's going to become for you to use your laser effectively. So if you're not using loops, I would encourage you to get a set of loops for yourself. And if you are using loops, I think you can look at a higher power. Often people will find about 4.5 times magnification to be a key sort of point at which diode lasers and lasers in general become easier to use. So without any further ado, let's get started, and we'll concentrate on the first part, being laser physics and laser science. As mentioned, for the last 11 years or so, I've been using a variety of lasers in my practice, including soft tissue lasers and hard tissue lasers. And over the last couple months, we've been using the Picasso laser and been finding it to be a very interesting, very nice product. And we're going to focus on the Picasso for this particular presentation. You can see here I'm using an operating microscope, and we have a variety of lasers in the practice. I think it's important that you emphasize in your practice that you are using lasers, because patients are attracted to the fact that you're using technology. They understand lasers from laser eye surgery, and they're willing to get involved with lasers in your practice, and it can be a key part of bringing new patients into your practice is to emphasize wherever possible, like we've done in our cards, the fact that you do use lasers, and in our case we're using an operating microscope to help us see. So as I mentioned, the first part of today is going to be concentrating on basic laser science and laser physics. And after we've done that, then we'll cover the top 10 procedures that you can use your diode for. I want to thank AMD Lasers and the Picasso laser. It's a very nice product, as I mentioned. A diode is a diode, but this particular laser has some very unique features to it. It's priced very reasonably, it's packaged well, it's reliable, and I really think it's a great product. It's going to become very, very popular in the dental community because of its features and also its price. Let's begin with the first topic, and that's basic laser physics and laser science. As mentioned, you don't have to be an Einstein, but I do think you need to understand a little bit about how your laser works. Laser stands for light. It's amplified, it's stimulated emission of radiation. People get concerned with the term radiation, and you should understand that lasers are actually non-ionizing radiation. They're non-damaging to cellular DNA. So it's important to remember that when you are using laser, yes, you are stimulating an emission of radiation, but it is not going to be damaging to the patient. Patients are pretty comfortable with lasers, and laser eye surgery really has brought that forth. When you look at a laser, there are electrons that are spinning around the nucleus of an atom, and these electrons are spinning in a normal orbit. When you take an outside power source or an energy source and stimulate these electrons, they will actually enter a higher orbit. This orbit is unstable, and the electrons can't stay there. It's not possible for them to stay in that elevated orbit. So they must return to their original unstable form, or their stable form, and as they return to the stable form, they give off something in an energy that is called a photon. And it's these photons that we gather to make the laser. When you look at the inside of your laser and you were to look at the components of the laser itself, one key thing you'll see in all lasers is an optical resonator. It is a large tube. Inside this tube are many things, including the media that the laser is made from. Some are made from gases like CO2 or argon. Others are made from crystals, things like a diode crystal or an erbium crystal. These are the media that create the photons. But inside this tube you will find are all the photons, and these photons are going back and forth, and there is a partially reflective mirror on one side and a totally reflective mirror on the other side. When you have an outside energy source, a flash lamp or electricity stimulating this increase of photons, eventually they get to a high enough level that they can be released, and through a series of lenses the laser light can be focused and into a beam. The beam that we all know that you see with laser pointers and that we're familiar with, that beam is concentrated by these lenses. Laser light is different from ordinary white light. If we take an ordinary incandescent light bulb, there are a variety of wavelengths that come out. These are a variety of colors, a variety of different lengths, some of them being longer, some of them being shorter, and ordinary white light has all these particular wavelengths coming out of the bulb. In contrast, a laser energy is very cohesive, it is very focused, and it is efficient. That laser beam that comes out is very small. If you were to shine a flashlight, you would find that the flashlight beam would hit the wall and it spreads out and gets diffuse. Whereas we all know if you take a laser pointer and shine it at a building, the beam is still very, very focused and will travel great distances because of the monochromatic wavelength. So laser energy is different from normal white light. And the energy is all one wavelength, meaning all the peaks and valleys are at the same level, and that beam is very, very cohesive and very, very efficient in its energy source. When a laser beam interacts with tissue, we call it a laser-tissue interaction. One of four things can happen. All right? We can have the laser beam reflecting. That's why we want to minimize mirrored surfaces in your dental operatory, particularly for some of the longer wavelengths like CO2. But even for diode, if you can minimize the amount of reflective surfaces in your operatory, you'll find that there's less chance of reflection and scatter going into areas that you don't want to. The second thing is called scatter. And the laser can actually hit the tooth and scatter. And we used to use this with argon laser. It was a blue wavelength, 488 nanometers, and it was one of the earliest curing lights. We would use the laser to cure very rapidly, and the beam would hit the resin and cause scattering, and the scattering is what would set the resin. Nowadays we have pack lights and different light systems that will allow us to cure, and we don't need the argon laser like it was used earlier on. The third thing is absorption, and this is the key thing that we want to see in laser dentistry. We want to see the laser beam being absorbed by either the tissue or by the tooth. The absorption of the energy by the tissue is what creates the reaction, and we'll talk about that in a minute, but the thing that we'd love is for the majority of the energy to be absorbed, not scattered, reflected, or transmitted. Transmission is the fourth possible interaction that can occur, and for instance, we can sometimes have a diode laser being transmitted through water and interacting with the tissue. Eye surgeons will also use lasers, and the laser beam is transmitted through the anterior portions of the eye and affecting the retina. If there are retinal tears or retinal bleeding, they can actually transmit the laser beam through and have it interacting with a deeper structure. So as mentioned, there are four different tissue interactions called RATs. It can be reflected, absorbed, which is what we really want. It can be transmitted, or there can be a scattering. When the laser beam hits a tissue, there is a localized area of cutting. When the diode cuts, or when the hard tissue laser cuts, there is this initial zone of cutting, and deeper underneath is a zone of coagulation, and finally a zone of edema. Ideally, we'd like to have the zone of edema to be very small. And so the less the depth of penetration of the laser beam, the less the lateral thermal damage, the better. As mentioned, the beam as it interacts can be reflected, it can be scattered, it can be absorbed, and that's There are a variety of factors that can affect how the laser interacts with the tissue. Some of these things are very simple. Time. The basic element of time, the longer you leave the laser on, the more cutting it will do, the more thermal damage it will do. So again, you want to try and use the lowest power possible, but at the same time, try and minimize the amount of time that you're interacting with the tissue to minimize the lateral thermal damage that will occur. The second thing is power. It's like the radio in your car. You can turn it up or turn it down. And you will find that the more magnification you use, the lower the power that you'll need to accomplish the same task. As I tell the story, I was lecturing once and a person was coming to me saying that he was noticing a lot of charring. He was noticing a lot of recession. And when I talked to him about the settings he was using 2.5 to 3 watts continuous wave with his diode laser to trough. I said, do you notice a lot of darkness? He says, yeah, but if I use anything less, it really takes a long time for me to trough. And I asked him about the amount of magnification he was using. He said, no, I'm not using any magnification. And I said to him, you may find that your power densities will decrease if you just simply increase the amount of magnification by 2 or 2.5 times. You may find that you are decreasing the level of interaction that's going to happen. You're going to be able to see easier. You're going to be able to use lower settings. Distance and area. In many laser beams, if you touch the tissue, you'll have a direct effect. And the further you pull away, the less interaction you will have. We call this defocusing the beam. So a focused beam is in contact with the tissue. A defocused beam is pulled away. Clinically, most things we do with a diode laser, we will have the tip in contact. And any time that tip is in contact, it should be initiated, meaning that the tip should be darkened either with cork, that you touch it into the cork, or articulating ribbon. And what this does is concentrates the energy at the tip and creates a hot tip effect. If you are in contact with the tissue, your tip needs to be initiated. If you are in non-contact, something for like an aphthous ulcer treatment, controlling of bleeding, hemostasis, those particular items are in non-contact. You want the laser energy to penetrate deeper, so you will not initiate the tip. So the energy from the laser itself can go through the tip and penetrate deeper into the underlying tissue. So again, distance and area, contact means focused, and pulling away means defocused, and as you pull away, you will find that your beam goes from small to larger. There are two different types of lasers, really. There's a continuous laser. A diode laser is continuous. You step on the pedal and the energy is on. It's called continuous wave. What they've done in diode lasers is they've got a little mirror inside and that will rotate. And as it rotates, it can chop your beam up or gate the beam. It's not an actual pulse, but it will get the beam cut up and chopped up so that you can actually give the tissue a chance to relax instead of having just the energy on all the time. A continuous laser is always on. A pulse laser will actually give you a short, intense pulse, something like lightning almost. And the hard tissue lasers or erbium lasers are pulsed. They will actually create a pulse that is very short in duration. It can be anywhere from 50 to 300 microseconds, millions of a second, and that short, intense pulse creates a very high peak power of energy. And then there's a large period of time for the tissue to relax before the next pulse happens. So these are the basic absorption factors that occur with lasers. Time, power, distance and area, and whether the laser is continuous or pulsed. The laser delivery system, how the energy comes out of the laser itself, can be one of 3 varieties. Diodes are typically an optical fiber, meaning that the energy from the box, from the laser itself, is carried to the surgical site by a fiber. These fibers can vary in size from 200 microns, which is very, very small, up to 600 microns. And 600 microns is a reasonably large size, the most common being around 400 microns or 4/10 of a millimeter in diameter. Other alternatives, which are often found in other wavelengths like CO2 or in erbium, is either an articulated arm, which is a hollow tube with mirrors on the inside, and the energy from the box, from the laser, bounces along the hollow tube in the mirrors to get to the surgical site, or a hollow waveguide, which is a semi-rigid tube with a reflective coating on the inside. For sake of today, we'll talk mainly about the optical fiber here, and it is composed of really a jacket on the outside, which is often silicone, a cladding or insulation on the inside, which is an opaque polymer, and finally the core, which is a quartz glass. And it's this core glass product that is the part that we initiate, and it's the part that we cleave from the fiber itself. So optical fibers is what diode lasers are primarily made from. You see here two different varieties of laser delivery systems. The top one being for a optical fiber that's coming into a pen type system, and many diode lasers are having a laser delivery system like this. This is a 300 micron fiber. They come in 400 or 600 microns as well. Some of the erbium lasers, hard tissue lasers, have tips that are autoclavable. They are different sizes, different diameters, different lengths, and also different curves in some of them. So this is a erbium laser, and there is a autoclavable tip. This particular system with the optical fiber, for diodes, you have to cleave, remove after each patient the portion that you've cleaved, and start fresh and initiate the new tip. One key thing to remember with all lasers is that they are end cutting. It's an important concept to grasp. It is one of the things that makes lasers more difficult for the average dentist initially. The reason being is that when you use the laser, you cannot really use the sides to cut through. Unlike a burr, where you are able to use the sides or periphery of the burr to cut, or even a scalpel, whereas you drag the scalpel through, it's the process of dragging that causes the cutting. Lasers are all end cutting. And what this means is that you have to be able to let the light do the cutting. The physical act of dragging the tip through will not do your cutting, and in fact, in many instances, can increase the amount of bleeding. So you have to be patient, slow, small brush-like strokes, and then allow the light to do the cutting, recognizing that the light is in most cases penetrating directly down. If you initiate the tip and the sides of a diode laser, you can get some of the energy being transmitted laterally in the tip itself, but for the most part, all lasers are end cutting. So this means you can't really go sideways with a hard tissue laser, that you have to vary the angle of your tip in order to cut. And it also means that when you have a coagulum building up on the end of your diode, you have to stop and remove that coagulum, because it will actually absorb the laser energy and slow down the cutting process. So if you're troughing and you notice a coagulum building up on the end of your laser, stop, clean it off, get it clean with just initiated tip, and restart. If you're doing laser troughing for multiple teeth, you may in fact have to stop, cleave your fiber tip, and then restart with a new initiated tip, because you'll find that the tip starts to get a lot of coagulum on it that you cannot remove, or the tip gets ragged or chipped with the laser being used constantly. All dental lasers work with a laser tissue interaction that is primarily photothermal. The light is turned into heat, and as the laser light is turned into heat, that is what causes the laser tissue interaction. So photothermal nature is the actual method by which the laser causes a tissue interaction. When you look at lasers in dentistry, there are two different types. There's lasers in soft tissue and lasers in hard tissue dentistry. Soft tissue dentistry, the laser energy is absorbed by the soft tissue. And what happens is you will find that as the energy comes out, it is absorbed by melanin, hemoglobin, or by pigment in the soft tissue. You'll find that as the energy comes out, it will cause a localized cut zone, or a zone of ablation. And as that zone of ablation occurs, you will find deeper there will be areas of coagulation, and deeper to that a zone of edema. So again, the laser beam is absorbed by either hemoglobin or water or melanin, and it's absorbed by pigment. The chromophore is pigment, and what happens is the energy beam is absorbed by the pigment, and it's this interaction with these that causes the reaction. The photothermal effect causes the cutting of tissue and for coagulation to occur. Hard tissue is a little different. The chromophore in hard tissue is not so much melanin or pigment, but is in fact water. All areas of tissue have water. Soft tissue has 90% water. Enamel has 6 to 10% water. Dentin a little higher, and caries is a little bit higher than that. So you'll find that because of that, all tissue has water in it. And what happens is, as the laser beam comes out, it will interact with the hard tissue, and the laser light is absorbed by moisture. We get a very rapid rise in temperature, and as that occurs, what happens is you will find a small expansion occurs in that area, and you get a zone of ablation that causes a piece of tooth to come out. It's very rapid, and because of this, not much of the heat is transferred to the surrounding tissue. As it happens, you get a little very small zone of ablation that occurs, and you will find that the piece will actually pop out of the tooth, 30 to 50 micron crater that occurs in that area. When the hard tissue laser is working, you will find there is what we call an acoustic mechanical noise, and it's actually a popping noise that you will hear pop, 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 pop with the hard tissue lasers. With the soft tissue lasers, you don't necessarily hear that, but you hear that with the hard tissue lasers, and you will observe that that is in conjunction with the pulse rate. When you look at a soft tissue laser or hard tissue laser, there is temperatures that you can reach as you increase the energy through the tip. So for instance, if you were very, very low power settings, 0.1, 0.2 watts, you'll find that you may warm up the tissue. You may get a little bit of warmth, hyperthermia, that occurs between 37 to 50 degrees Celsius. That hyperthermia or warming of the tissue can actually, in many cases, speed up the healing. We call it photomodulation or low-level laser therapy. Low-level or cold lasers will do very, very little warmth of tissue, but they will stimulate the healing and improve the healing simply by gentle warmth and causing an increase in circulation. As we continue up the power scale, you will find that at 60 degrees centigrade, you will find coagulation occurs. And coagulation is something that we want to use with diodes when we're doing for hemostasis, for clotting blood sockets, etc. And you'll want to see coagulation occurring at 60 degrees. 70 to 90 degrees Celsius is an interesting point. We get tissue welding there. So you can actually get the tissue to sort of meld to each other, minimizing in some cases the amount of sutures that you have to use, and to be able to get your incision to close over and to improve the healing. As you raise the temperature more, from 70 to 90 degrees, which clinically might be 0.4, 0.5 watts continuous wave, as you go beyond that, you get to where you really want to be. Between 100 to 150 degrees centigrade, you get tissue vaporization. This is where you get ablation without any negative effects, and where you can actually see a zone of cutting. So this is where we want to be. When we start to get beyond 150 and closer to 200 degrees, you will start to notice carbonization or charring. So when you are looking, carefully focus on the zone of cutting and your laser tissue interaction. And if you start to notice darkening of the tissue, charring occurring, your energy settings are too high. If you notice that you're not getting a zone of vaporization, but the tissue is kind of gloopy, gluing onto each other, getting a white sort of slough, but it's not actually cutting, you probably find that you're actually not getting up to a high enough level to cause vaporization. So again, this gives you a basic understanding of the temperatures necessary, and wherever possible, avoid going too high, because this is going to cause post-op sensitivity, delayed healing, and in some cases recession of the tissue. The thermal effect on tissue, as I mentioned before, is controlled by a number of different things, including the power density. The larger the tip, the lower the energy settings. So as you go from a 600 micron tip to a 400 micron, which is smaller, the energy that's coming out of that tip is more concentrated, let's say. And what that allows the clinician to do is use lower settings, and they must use lower settings if they are using smaller fibers. Cooling. Cooling can happen through water. If you are constantly spraying a spray of water, you will cool the tissue down, but it will take you longer to cut. You may have less charring, but you may have more of a ragged cut. You can also cool with either a stream of air, so it's effective if you're doing something like tissue recontouring, a gingivectomy without anesthetic, which is topical. If the patient's feeling it, just a gentle stream of air or some circulation of the air with high volume suction Those two things will help you in cooling the tissue and perhaps decreasing the sensitivity. Duration of exposure. As I mentioned, the longer that you leave the laser on, the greater the effect. And you want to use the minimal amount of energy and time in accomplishing the procedure. The specific wavelength, you will find that some wavelengths penetrate deeper than others. Erbium and CO2 lasers, CO2 is a soft tissue laser, erbium is a hard tissue laser, they have a very limited depth of penetration. Nd:YAG, which is a soft tissue laser, can penetrate deeper, 4 millimeters or so, whereas a diode laser is in between. So again, the depth of penetration can affect deeper tissue levels, and that's why the different wavelengths have different penetration levels. You will also find the emission mode, whether it's pulsed or continuous wave. Typically, pulsed lasers give tissue a chance to relax, whereas continuous wave, it's always on. So giving the tissue a chance to relax will again allow it to cool down between subsequent pulses or between the subsequent gated form of the continuous wave. And finally, tissue characteristics. If the tissue is very fibrotic or very white, keratinized, it has less pigment in it, will require higher energy to cut, whereas very granulated or edematous tissue will typically require lower energies to cut. We're talking about continuous and pulse, and when you have a diode laser and you step on the pedal at 3 watts, you get a continuous pulse or continuous energy setting of 3 watts for as long as you have your foot on the pedal. So if you have your foot on the pedal for 2 seconds, you'll get 3 watts of energy for that whole time that you're on. If you have a pulsed laser, be it an erbium laser, or if you want to chop your beam up, you will find that you'll have 3 watts while you step on it, and then there is an area of tissue relaxation where the energy is not hitting the tissue, and you are able at this point to allow for the tissue to relax between pulses. So pulsed lasers, in some respects, will give you a greater chance to have less iatrogenic damage to surrounding tissue. If you look here, this is again a slide provided by Don Cluse. He used a diode, soft tissue laser, 400 microns. This is continuous wave. CW means continuous wave. 3 different frenectomies done, one at 1.2, one at 1.4, one at 1.8. If you were to look closely at these, you would find that there is less charring here at the 1.2 watts than at the 1.8. You can see that there is more lateral thermal damage and there is more charring, will give you delayed healing initially and perhaps more post-op sensitivity here. When you get to the 1.2 watts, you can see that there's nice healing or nice incision, not as much charring, and again, you want to use the lowest energy possible. If you're using a pulse setting, you may not want to use 1.2 watts continuous wave. Perhaps you want to use 1.4 or 2.2 watts. You can use higher energy because there are periods of time where the tissue is relaxed between those gated pulses. What's interesting is that 90 days post-operatively, they're all healed. It's the period of time initially, the first week or 2 weeks, where the difference occurs. Cutting dynamics, as I mentioned to you earlier, in very granulated tissue, you will find that you need to use a lower amount of energy. Perhaps instead of 1 watt, in very granulated tissue, you could use 0.8 watts and still cut effectively, continuous wave. But if the tissue is very keratinized, something like an operculectomy, you may need to use much higher energy settings, 1.4 watts, 1.6 watts continuous wave, maybe even 3 watts pulsed, 30 microseconds duration on, 30 microseconds duration, the interval of between gated pulses. So again, fibrous tissue requires more energy than normal. Normal requires more energy than a granulation tissue. As I mentioned earlier, depth of penetration is a key thing. A diode laser and an Nd:YAG will penetrate deeper than a erbium laser, which is hard tissue, and it will penetrate deeper than a CO2 laser, which is again a soft tissue and very long wavelength. So you have to remember that some of your lasers will have a deeper penetration, causing more lateral thermal damage the longer that it's held on. We call the electromagnetic spectrum the spectrum that occurs from very short wavelengths to very long wavelengths. Radio waves, microwaves are typically longer wavelengths The visible region of light, which is the reds and the blues and the purples, the colors we see in the rainbow, occur in this area. And those visible regions are really between 400 and 700, around there, nanometers. And 488 is blue. It is argon, for instance, the old argon. 514 is green. 600s are red. And as you get up, you get to really around 700, where you start to lose the visible range of radiation. Below that, you will find ultraviolet, X-rays, which we know can be damaging to cellular DNA, in the 100 nanometer, and below that, gamma rays. So again, you can see ultraviolet on the left-hand side of the electromagnetic spectrum, the visible wavelengths from blue through to red, and the soft tissue lasers, which are beyond the visible wavelengths, fall between 800, 810 nanometers up to 980. There are even diodes now that at the 1064. The Picasso laser is in the 800 range, 800 to 830. The erbium lasers are erbium YAG and erbium chromium. These are close to 3,000. The ND YAG is at 1,000. And finally, the longest wavelength, which again is soft tissue, is CO2. And these long wavelengths can travel quite a distance. So again, you want to be really careful with minimizing the reflective surfaces when you're using these longer wavelengths. What's really important when you look at this absorption curve and the different absorption of tissue components is to be able to look individually at the different lines. In this case, red is hemoglobin, black is melanin, this black is hydroxyapatite, and the blue is water. Within these different tissue compounds, you will find there are different absorptions. And if you look at the bottom, you can see the various wavelengths: argon, diode, Nd:YAG, erbiums, and finally the long wavelengths. The diodes are in this region here. So if we look up from the diodes, we can see that they are not very well absorbed in water. Water doesn't absorb the diode that well, nor does hydroxyapatite. But if we look, there is quite an absorption in both hemoglobin and in melanin. Conversely, when we look at the erbiums are not at all absorbed in hemoglobin or melanin. Effectively, they are absorbed very well in hydroxyapatite and in water. So the difference is, when you want to cut a tooth and you're required to have water absorption, the diode won't do anything. But the erbium, which has a peak here for water, is much better absorbed. That wavelength is much better absorbed and is able to cut hard tooth. Whereas it doesn't have any effect in the hemostasis, so you will find that if you are cutting soft tissue with an erbium laser, you're going to typically get more bleeding. It's important to notice that with erbium lasers, there is no absorption or very little absorption in the hemoglobin. And there is much better absorption in water. Conversely, the diodes, which are soft tissue, are better absorbed in hemoglobin and melanin, and that is why they are much better at coagulating and hemostasis than the erbium lasers. So if you look, you'll find that the erbium lasers there are absorbed in water and hydroxyapatite. The diode lasers are absorbed in hemoglobin and melanin to a much greater degree. Soft tissue lasers cauterize and do a better job with hemostasis than hard tissue lasers. When you look at what I mentioned there with that absorption spectrum, what you'll find is, because they're absorbed by melanin and hemoglobin and not by water or hydroxyapatite, they coagulate better. Hard tissue lasers are absorbed well by water and hydroxyapatite, and as mentioned, not by melanin or hemoglobin, so they will cut tooth structure and bone, but they don't do as good a job on soft tissue with coagulation. Erbium lasers are hard tissue lasers. They have less hemostasis, very superficial in their cut. They're faster in many areas, and they shave or plane the tissues away. Diode lasers have much better hemostasis. They're deeper, though, penetrating. They're slower cutting, and you have to cut from dot to dot rather than cutting in a plane. So again, you can see here the absorption spectrums for argon, for diode, for Nd:YAG, and you'll find that these are all soft tissue. This was for curing. This is a hard tissue laser, and again, we get to the soft tissue lasers. What's predominant now is these soft tissue lasers, which are coming out in small packages, portable, dependable, reliable, and the Picasso laser from AMD falls into this category as a soft tissue laser in the diode region, in the 810 region. And that's what we're going to focus on. So when you look at diodes, diodes can ablate soft tissue very well, but they'll have very little effect on hard tissue. If you're crown trough and you touch the tooth, you may find a very, very subtle area of charring that is very paper thin. One stroke of your diamond burr, it's gone, that dot. The chromophores for diodes are hemoglobin and melanin, and water to a lesser degree. Most of the diodes fall in this region, but there are some 980 nanometer and 1064 diodes as well. The diode tip should always be blackened or initiated when you're doing something in contact. To cut in contact, you need to create a hot tip, so you need to initiate your tip. We went over that in other parts of the training. And the procedures can be done in conjunction with restorative cosmetic procedures, such as crowns and veneers, or separately. There are procedures that are specifically designed for like fibroma removal, or hemangiomas, or frenectomies, where you may not be doing them in combination with other cosmetic procedures. You may also be using your laser to do some crown troughing in cosmetic procedures with crowns and veneers.